I want to welcome you all tonight to the latest edition of the Distributed Learning and Rural Initiatives webinar series. We're really excited about this topic tonight. Tonight we're focusing on adolescent mental health in the time of COVID-19. My name is Aaron Johnston. I'm the Associate Dean for Distributed Learning and Rural Initiatives at the University of Calgary. And this is an exciting webinar for us because for the first time, we're partnering with another institution, the Distributed Medical Education Group at McMaster University, to do this webinar in a partnered format to leverage our resources and hear from different parts of the country about their take on this important topic. As we begin tonight, I want to acknowledge the land that we're broadcasting from here in Calgary. This is a national webinar, and so you might be on different land than I am tonight. So as I'm talking about the land that I'm on, I'd encourage you to think about the place that you're sitting at tonight, watching this broadcast. What does that land mean to you? How are you connected to it? Who are the original inhabitants of that land, and who are the current inhabitants of that land? And what can you do to be a good steward of that land? In Calgary, this is part of traditional Blackfoot territory and the Treaty 7 area of southern Alberta. It's the traditional home of the Siksika, the Piikani, the Tsuut'ina, the Stoney Nakoda First Nations, and Calgary is also home to Métis Nation of Alberta Region 3. My co-host tonight is Dr. Deborah Wilkes-Whitehall. I'll pass it over to her as well. Deborah?
Hello, everybody, and thank you so much, Aaron. It's an honor and a privilege to be here collaborating with the University of Calgary, and I am coming to you from the Niagara Regional Campus of McMaster University, one of the distributed learning sites. And I would like to acknowledge that McMaster University, Niagara Regional Campus, acknowledges the land on which we gather. It is the traditional territory of the Haudenosaunee and the Anishinaabe peoples, many of whom continue to live and work here today. The territory is covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Today, the gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging reminds us that our great standard of living is directly related to the resources and friendship of Indigenous people. As well as we are distributed sites, McMaster University, the Waterloo Regional Campus, acknowledges that they live and work on the traditional territory of the neutral Anishinaabe and Haudenosaunee peoples. The Waterloo Regional Campus is situated on the Haldeman Tract, the land promised to the Six Nations that includes 10 kilometers on each side of the Grand River. And McMaster University, the Hamilton campus, recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish with One Spoon Wampum Agreement. Thank you.
Thanks, Deborah. I want to give just a few Zoom housekeeping items to discuss how we're going to use Zoom tonight. I'm sure everybody on the call has used Zoom for more meetings than they can count at this point. But tonight we're using the Zoom webinar platform to present. The presenters will each give a presentation. We have 4 great presenters giving 3 great presentations tonight. After each of our presentations, there will be time for a few targeted questions. And at the end of the presentation, there'll be opportunity for a panel discussion where we can ask some bigger questions or questions that come up in the chat or the Q&A. At the bottom of your screen, you'll see a few buttons in Zoom. You'll see a participant list, a chat box, and a Q&A box. I'd encourage you to open the participant list and the chat list as well. The chat list will allow the participants of our webinar to interact with each other, to talk about how the ideas being presented tonight work in their region, or to interact with panelists as we go on through the evening. Jenna says she doesn't see a participant list, so that may be disabled in some versions of Zoom. As long as you can see the chat, Jenna, hopefully you'll be able to interact with people. Okay, it looks like just the Q&A and chat. So I'd encourage people to open the Q&A and the chat. In the Q&A, I'd encourage people to use that to put questions. So if you put questions, Dr. Wilkes-Whitehall and myself will try to pick questions out of there to pose to our panelists as we go through the evening, and we'll try to interact with you in the chat. If you're having any technical problems, please put them in the chat, and my team, the Distributed Learning and Rural Initiatives team, who's running all the back end of this webinar tonight, will try their best to help you out. We want to just mention, because we have the opportunity to be in front of preceptors tonight, that at the University of Calgary, we do have teaching opportunities. If you're a preceptor in Southern Alberta who's new to us or wants more teaching opportunities, please feel free to reach out to my office at Distributed Learning and Rural Initiatives, and we can help find the teaching opportunities that match the sort of teaching that you'd like to be doing. Deborah?
And yes, thank you so much. And I would like to say a similar thing for Niagara Regional Campus. If you are interested in any teaching opportunities, please do contact the campus. And we have an annual faculty retreat. This has been a very well-attended event, and this year, of course, it cannot be in person. So it will be January 30th from 9 to 12:30 on Zoom, and it is to help with health and wellness for our faculty and our teachers. So if you are interested, please contact Devin Ainsley. Thank you.
Get into some slides. Can you take us to the webinar objectives slide to start with?
I will do this one. So the webinar at the webinar objectives at the end of this program, you will hopefully be equipped to, one, identify the impact of COVID-19 pandemic on adolescent mental health, two, develop approaches for interacting with adolescent patients and on virtual platforms, and three, investigate the future state of adolescent mental health during the COVID-19 pandemic. Aaron?
Great, next slide, please. The mitigating potential bias. So we always think about bias when we do these webinars. We want to make sure that we're giving you as unbiased information as possible. And in order to do that, we make sure that we don't have any sponsors as representatives on our planning committee, and that we carefully choose topics for the program. You'll notice that you receive a survey in your email after our program tonight, and that we would encourage you to suggest topics for future webinars. We try to use an audience-driven, participation-based way to generate the topics that we come up with, and that helps them be free of bias. We've all had individual discussions with each speaker regarding expected learning outcomes and teaching formats, and we don't think that there's any undue bias in this program. Next slide, please.
This program has not received any form of financial or in-kind support, and there is no potential conflict of interest for the program as a whole. The individual speakers will be reviewing any of their disclaimers and potential conflicts of interest in, if there's anything specific they wish to share with you. Next slide.
And finally, this program and all of the slides that we're going to be presenting tonight, we believe are compliant with the copyright rules of the University of Calgary, and where we are using any third-party material, we'll make sure that it's properly cited. And we can go to the next slide. Now that we're done with the disclosures, I'm really pleased to be able to introduce our first two speakers, Dr. April Elliott and Dr. Monique Jericho. Dr. Elliott and Jericho have done speaking engagements for Distributed Learning and Rural Initiative before, and we very much appreciate their willingness to come back and help us out again. Dr. April Elliott is a pediatrician and adolescent medicine physician at the Alberta Children's Hospital here in Calgary. She's head of the section of adolescent medicine in the Department of Pediatrics. And Dr. Monique Jericho is a physician working in the field of adolescent and child psychiatry. She has a specific clinical interest in eating disorders and in youth and families whose medical, psychological, and social needs don't fit easily into existing medical frameworks. Welcome, Dr. Elliott and Dr. Jericho.
Thank you so much for that introduction. I wonder if we could move to the first slide. Well, that's me, and my only affiliation to disclose to you today is that I am indeed with Alberta Health Services.
Next slide. And thank you so much. I have an advisory position, a non-financial one with Lions Heart Foundation, and I also have a grant with the Pediatric Innovation Award and also an emerging adult grant with the Alberta Children's Hospital Foundation, and I'm affiliated with Alberta Health Services. Next slide.
All right, well, as mentioned, it is wonderful to be here today, and so nice to see that so many of us are invested enough in our youth that we're willing to be in front of a monitor for a few more hours of our day. Today, our hope is to be able to discuss a little bit about the current status, sort of the state of affairs that we're all living through when it comes to the health and mental health of adolescents through this time. We are hoping to get back to basics a little bit and discuss what adolescent needs are, and maybe discuss and review how that interfaces with the pandemic. Beyond that, we will get into some details around how we will be working with youth now and a little bit more about what to focus on now in these given circumstances. Next slide, please. So we all know that we are facing unusual, unprecedented times, and we certainly do have some idea of the nature of how much mental health burden is being placed upon youth and then, I guess, transferred to us as care providers. This is just a tiny little snapshot looking at the world that Dr. Elliott and I occupy. This is looking at admissions for eating disorder patients in our world, and you can see the percentage increases are quite substantial, and we just see this as an example of what each and every one of us is facing. And we know that if we're facing these sorts of numbers and changes in our tertiary care center, this is an example of really the huge tsunami that is going on beneath this, and what particularly people in the community are having to respond to. I would add that what we're seeing is far more acute, which again speaks to the burden of care for people caring for youth all through the province and the country. Next slide, please.
Thank you, Dr. Jericho. So we have heard from our emergency physicians that they have seen a huge increase in mental health presentations, and doing an informal review of the Tableau dashboard, it looks like there's been about a 62% increase in mental health presentations in the last quarter. So we know the problems there on all levels. And I just wanted to start by grounding us all in a situation that I'm sure each one of you has encountered or some form of it. So we're just going to go to a young person's life. This young person's name is Carla, and she's 15 years old. She lives in a family where her father has just been laid off. He is 47 years old, and he is a bartender, and he also struggles with an alcohol use disorder. Her stepmother, Cindy, is a personal support worker at a long-term care home, and she has a younger sibling, 7 years old. Really, since COVID started, her father has really been spiraling out of control. He lost his job, there's been financial stress, and he's really angered by the noisy household. He feels that his drinking calms him, but unfortunately, there's been verbal and recently physical abuse in hitting his wife. His wife is working long hours due to COVID positive co-workers, as well as isolation requirements, and she also has to manage homeschooling. She's getting quite frightened about Joe's unpredictability and is fearful of leaving him alone with the children. She's very worried about Carla, the teenager who has recently shut herself away. She appears to be losing weight, and recently Cindy thinks she stole money from her. She was unfortunately brought home by the police at 2 a.m. and the family didn't even know she was gone. Carla herself feels nothing. She just misses her friends and doing her sports. Like, COVID rules are just so unfair. She can't play hockey, and yet a couple weeks ago, adults could still go to bars and restaurants. Dad's behavior just worried her at the start, but now she's angry with him, and he's ruining everything. She's scared for her stepmom and her sister, who I think has been wetting the bed, and just doesn't seem to be any point in doing anything. She just basically stays in her room on her device. The other night, she met up with some friends from school and tried some weed, but the police caught them and threatened a fine. She's starting to wonder if anyone would notice if she's not around. Cindy, her stepmom, has made a virtual appointment with you, her family physician, who has been double booked and has been dealing with this crisis and distress for months. Let's all just take a collective breath and notice how we are experiencing this. Next slide.
So when we start to talk about the impact of the pandemic and all its restrictions on youth, it's very easy to get caught up in all of the ancillary stories and everything else that's happening around us, and to feel like we're not grounded ourselves. Which is why we wanted to start here by talking about, what do we know about adolescence? What is going on for people as they traverse this phase of life? Now, what we know is that adolescents are absolutely wired for risk and so for social learning. Their brains are going through tremendous renovations through this point in their lives, which affords for a lot of opportunity, but also brings with it risk. We know that risk salience is up. This is what allows for young people to explore their environments and to challenge themselves, but it also puts them into some situations that can be potentially negative for them. But this is what's happening, right? All the time. Now, our context is different. We also know that this is a time where youth need to develop an identity, where they need to kind of sort out a few things about who they are and come to sort of a grounded place within themselves. And that does require a context. It requires a social context with exposure. Comparison is important. Time with peers is vital. And they need to practice. They need to be able to try things out. This is particularly relevant when we're talking about issues related to gender identity and also sexuality. The other thing to flag is that we know that adolescence is a time where we see the emergence of a lot of long, chronic mental illnesses. So psychosis, the onset of depression, the onset of a variety of different mental illnesses. This is sort of a hot time for that. So these things are cropping up. And when we're seeing them in this context, we can get confused. The other piece, obviously, to flag is that the risk for suicide peaks somewhere around 15 or 16 years of age. Can we have the next slide, please? So when we put that all together and reflect on the case that Dr. Elliott shared, you know, this was a youth that we're talking about who needs to have a context to develop a self-esteem and a healthy identity. She needs to get away from her family and have some autonomy. But the circumstances are so difficult for that. She can't leave. There are so many outlets that have been shut down for her. And then she's in an environment that's like a pressure cooker with all of the other stressors. So is it a surprise when we're hearing that these teens are hiding in their rooms, that they're isolating themselves? They're also in this space of trying to develop an identity, as I'd mentioned, around sexuality that can put them at some degree of risk, particularly when it comes to engagement via screens. And all of these other pieces are really such important, critical parts of development that are having to be tweaked, changed, and sometimes just put on the back burner through all of what we're going through right now. So a huge burden on this population. Next slide, please. And
I think this just summarizes some of the things that Dr. Jericho have already spoken to, really COVID takes away so many opportunities and healthy risk-taking times for these youth. And now with even more restrictions, what their normal development is now being deemed to be, warranting a fine or being out late. And these are things that youth need to do to develop properly. I just want to highlight that loss of milestones is critical. They're not graduating. Do you remember last year when people had to line up in cars and watch young people graduate, or kids haven't been able to go to summer camps or participate in sporting events? And so there's a lot of loss on top of the uncertainty and the isolation that they're going through. And Carla, in the example, also had so much social and familial stress as well that she's dealing with. Next slide.
Okay. So how do we work with youth now? And I think, again, it's nice to be able to sort of step back and say, you know what, we actually know a lot about how to engage with our patients. Sometimes we can get lost in that when there's so much change and there's so much that's new and so much distress. But remembering always that relationship establishment is the #1 goal. You're not going to ever get everything in one visit, and even less so now in the context of, technical challenges, internet disruptions. It is not possible to get everything in one shot. So what is critical is to develop the trust and the alliance that will allow you to meet again. And so in order to do that, there's a few things to kind of bear in mind. So confidentiality is absolutely key. A youth has to know that what they share with you is going to be secret. It is not going to be recorded. They have to know that there are other ways with which they can connect with you if they do not have privacy. So allowing them to chat with you in Zoom to confirm that there is no one else around, no one else in the room. I know Dr. Elliott and I, who've been working jointly on a number of assessments, have many times been taken aback when we thought we were working with a young person exclusively, only later to find out that someone was sitting across from them in a couch like the whole time listening in. So confirming this and really following up around that is so, so important. And it is also really important that a young person's aware that you will be meeting with them privately. So even if the family is joining you for some aspect of the conversation, establish those boundaries, let them know that they are a priority. And in addition to this, a really important key point, given the screen use, the internet disruption, and everything else that's going on, get a phone number and an alternate contact right from the get-go so that you will be able to reconnect if things go haywire. Next slide, please. All right. So when we're looking at our stance and how to address youth, Dr. Elliott and I refer to this as a coaching stance versus a medical stance. And Dr. Elliott will speak more to that in the next slide. But really what we're looking towards here is, how do we best engage with youth in a way that will fulfill those hopes we have to connect in a truthful manner, in a way that allows them to trust us and to return to us and to share with us. But also critically important here is that we acknowledge the broader family and issues. So in the case of Carla, for instance, there was so much going on there that in a brief encounter over Zoom, you would just be swimming in all those details, in all the distress, in all of the issues. And I think that we have to remember that when we have a precious opportunity to engage with the youth, we must be the keepers of that appointment. We have to make sure that we maintain those boundaries for them. And maybe it's the case that mom needs her own appointment. It's certainly the case that maybe the younger child needs their own appointment, but we really need to make sure that we have that one-on-one time with them and not get lost in everything else that's going on, because sometimes that'll just lead to us walking out feeling even more befuddled. And finally, when we have that moment and that time with youth, we can also make sure that we're ensuring that they are safe And we can do a lot of that checking in. That's absolutely critical. Next slide, please.
So I think what is really important to highlight with the coaching stance is it is at a particular time. And so it's not in an emergency. There's definitely a time and place for coaching stance versus medical stance. But in my experience in especially virtual encounters, when I show up in a coaching stance, I show up with a posture that's very intentional. I have that engaged listening and really experiencing the person where they're currently at. And I know that we're all good at doing this, but it's even about reminding myself to be intentional about it. Using the 5 expressions, which are non-judgmental, being very curious, empathetic, open, and flexible, and trying to get away from that medical stance where they experience us as more hierarchical, or that we're the doctors with the answers. And I think sometimes we can get set up in that the parents say, now the doctor's going to tell you what to do, and being able to meet the youth where they're at, learn their strengths and how they're experiencing the situation is really going to make that rapport and alliance with the youth better and help you through those crises with the families. Next slide.
Okay, so we've talked a little bit about how to do the work, but in terms of what to focus on now, really looking at the context, it matters. You know, I think that we need to be aware of what is happening around youth, because youth are surrounded by other youth who are also struggling, who are also in pressure cookers. And we need to understand what's going on in terms of family, friends, context, school, all of those pieces, perhaps more so now because of all of the change and distress. And we need to name it. We need to validate this. I mean, we all know that there's certain amounts of what's happening there that are universal experiences, and universality is something that is validating for all of us when we can name that. But I think there's an opportunity here as well to talk about, hey, you know, as a teen, as a youth, as an adolescent, did you know that you're actually wired to want to get out of the house? You're wired to need these things. And that might help a youth to appreciate why this is so particularly challenging and so difficult for them, because it may not be as difficult for other members of the family. And this really can be punctuated, and it can be a wonderful moment of joining and also some psychoeducation that could really help to frame the circumstance. We also want to look for incongruity in the reporting always, but in particular now, we want to know, you know, are they actually coping? Like, what is happening day to day? Is this a youth who's ever getting out of bed? Is there any kind of routine? And sometimes that's actually a wonderful place to start in terms of supporting people in recovering their mental health, is to start with that routine that might be lacking and to start to figure out how to help them engage in places where they can. Next slide, please.
Mm-hmm. So I think often we're in the moment, we're dealing with the crisis at hand, but what's the new symptoms? What's the old symptoms? And we need to balance that with the chronic risk and the new acute risk. And what are the new coping strategies? We're seeing a lot of new diagnoses because youth are coping with their uncertainty, their isolation, their grief, and their loss. So we should be screening for self-harm, substance use, problematic internet use. We're inviting youth to be on screens more, but you know, the Kaiser report last year said 7 to 8 hours pre-COVID. Now we're probably looking at 10, even 15 hours. So are we looking at it? Is it productive? Are they taking breaks? They're controlling their eating. We're seeing that increase in eating disorders. Are we asking about eating patterns? So these are the things that we want to be looking at as the new things, because they're coping mechanisms with the situation. One of the things I often get with other physicians, they're like, but what if I don't know what's going on? What if I don't know the diagnosis? And I think there's so much healing that can happen just by listening and being in the moment with the young person. I know there's cues by Zoom. Even tonight, I wanted to see your faces so I could understand if, you know, you were engaged in this presentation. It's really challenging now, and even less over the phone. So if we're having consultations over the phone, really hard to know if what someone's saying is congruent to how they're feeling. So talking and listening is treatment. And remember that, that's a lot of that is psychoeducation, and it can be just as helpful as prescribing a medication. Can you treat things like their sleep and their anxiety, and be proactive to get those foundational things for them, even without a diagnosis? And online resources are so helpful, and we've provided many to the organizers so that they can provide those to you and reference them to families. Next slide. I just wanted to highlight, there's so many screening. There's the Columbia for depression, and there's the Scared for anxiety, and many others that we've given at reference, but I don't want people to forget HEADS, or the one that I use now that it's been updated by Kenneth Ginsburg and the Academy of Pediatrics, is that SHADES starts with strengths, and we want to be solution focused. And sometimes my conversations with youth are really about their strengths. And then later on come up the issues that their parents had, but then we have these strengths to build their resilience against or for solving some of those problems. So please refer to the SHADES assessment and the reference, because it's so helpful in these conversations. Next slide.
So this is a really challenging one. You know, many of us don't have the option to see people face to face, or we certainly have limitations and restrictions around that. But here are some considerations. And of course, every one of these presentations arises within a context, but we always want to be vigilant to new and significant self-harm. Eating disorder concerns, absolutely, you know, within our context, doing a lot of this work. What Dr. Elliott and I have come to realize is that it's very difficult to gauge how medically unwell somebody is, eyeballing them over Zoom. So if there are eating disorder concerns, it is worthwhile to have them come in, to have some of their medical parameters sort of established. Obviously, acute suicide risk. We have a lot of youth who we all work with who may have chronic risks. And the chronic risks are manageable, but it's this additional acuity that we need to be watching out for. The what else is the what else tipping the balance that is now precipitating more of a potential crisis. Obviously, if there's an emergence of severe psychopathology or somebody who you've been watching closely in the community, these people are really at risk, people with psychosis and so forth. We also want to be incredibly mindful of the distress and sometimes, unfortunately, the deterioration that is happening within the family system that's leading to violence and sometimes abuse. If you feel this is happening, if your spidey senses are telling you there is something that is not right, it's important to, you know, allow for a follow-up to happen in person if you can do it, right? Because if you don't, if you sit with that, you know, there's a burden on you too, right? So I think that's an important thing that we'll speak to in the next slide. But, you know, you also have to be able to go home at night and feel that your patients are safe enough. So sometimes if it's just for your own peace of mind, that's a reason to bring someone in. So just wanted to flag that. Next slide, please.
And finishing up, it kind of sweeps in there. We want to be mindful that we developed a tool to really help practitioners navigate challenging adolescent encounters. And it comes up now, if you think back to Carla, she's in this context where there's so much familial crisis going on in a larger context of COVID and so many restrictions. Also, you are in a pressure cooker and you have so much going on. Remember, you were double booked and you're fitting this young person into your schedule. And so we just want you to think about your own wellness and mental health as you go into these consults. So we developed this. So navigate as notice yourself. What is your current state of mind? Are you an emotional mind, rational mind? Are you in a wise mind state? And how are you going to approach this challenge that Carla is having? Are you attuned to the present moment? And are you present? Are you using mindfulness to be here and now and show up for this young person and for yourself? What's your body language? I know it's more challenging through virtual, but we can be very mindful about how, our background is and what's going on for us. Validate the other person's experience. So in terms of, their present context and their normative behaviors, and sometimes using validation can really help the young person feel that they're not alone. Again, go back to yourself. Check in with yourself. Are you being triggered by some of this conversation, or are things distracting you in the background? Be honest and be truthful with the young person that you're in a different context as well, and there may be interruptions.
So just a few other pieces here. More than ever, we may have to guess at the unspoken signals, but we do need to try to do that because we need to demonstrate that we are listening, that we're trying, that we're deeply wanting to understand the circumstances, and just expressing a desire to understand can be remarkably helpful, even if you might get it wrong. Reflecting what you've heard in terms of making sure we've got some accuracy, that we are indeed understanding. And of course, always maintaining truthfulness, being honest and open will allow for that trust to be established. And of course, everybody here is empathetic, and indeed, we all have all of these skills. But what we also know is that when we're living under these circumstances, working as hard as we have been, and also facing so much pain and suffering and difficulty within our patient population, it's easy for us to slip into a different state of mind and sometimes lose sight of some of these points here in our Navigate tools. So we wanted to just reinforce that you have those skills, and sometimes it's just a matter of bringing yourself back to them. So it really, really does make a difference in terms of engaging a youth, and be so helpful in terms of supporting a young person and their family.
Mm-hmm. And I think just in closing, we wanted to say, instead of having a presentation where we gave you all the references and resources and reviewed it, we just wanted to take some time to weave this in, and then you can go to the references, because I think it's important for you to have that felt experience of we recognize, and everyone can recognize what we're going through together universally. And that's the end of our section. Thank you.
Thanks so much, Dr. Jericho and Dr. Elliott. That was a great presentation. It felt to me, I had the feeling of that feeling of where you can be overwhelmed when you presented that case, how complicated that was. So I'm sure that resonated with a lot of people who are here with us tonight. I don't see a lot of questions in the chat. I wrote down about 3 questions of my own, but in the interest of keeping us on time, I'm going to pass it over to Deborah to introduce our next speaker.
Thank you so much. Yes, I have a few questions too, so we'll save that to the panel. So I am thrilled to present our next speaker, and thank you so much, by the way, Dr. Elliott and Dr. Jericho. That was amazing. Our next speaker is Dr. Javed Alou, and he is a community-based family physician in Toronto who provides care to patients with complex physical and mental health conditions. Among many other activities, he is active in providing mental health care collaboration through Project ECHO at the Center for Addiction and Mental Health, and through co-chairing a joint working group of the College of Family Physicians and the Canadian Psychiatric Association. So I give you Dr. Javed Alou.
Great, thank you so much. And that was a perfect presentation to actually lead off of. So thank you so much, April and Monique. So I think I'll talk to you about what it's like for our patients and clients now, what it's like growing up in the pandemic. So I'm Javed, I'm a family doctor in the community in Toronto and at the suburban boundary of the city with patients from a very large catchment area. And now during the pandemic, that's expanded even more as families have relocated to smaller towns and cities and semi-rural areas. So a lot of supports and structures have changed for them, and our ability to connect them has also changed. So I'll focus today on implementing what Monique and April introduced us to. So what strategies we can use in primary care to actually make this complex care work for mental health care for adolescents. And also share some surprising insights and experiences in caring for adolescents and young adults during this pandemic. So our focus is caring for those growing up in the pandemic, and how do we approach this as primary care or other clinicians. As a disclosure, so these are the research grants are from CHR and U of T, dealing with a number of areas in primary care change, from lipid management, antibiotic use, and also research for the use of virtual technology in the pandemic for mental health care. The companies I work with there are diabetes care, and the consulting fees are with the role I have with the Ontario College of Family Physicians on mentoring and primary care integration. And I've also done work with the Ontario Medical Association and the Section of Family Practice on mental health care policy. And I'm an educator, I was mentioned, with CAMH as well as Trillium Health Partners. And the Memotex work is on artificial intelligence and diabetes use. So this program here is without conflict or support. And so if we're looking at how we focus on those growing up in this pandemic, and for that, there's a quick definition to keep in mind. So though our vernacular and typical medical usage, we describe adolescents as being between the ages of 11 and 19, the definitions in the medical literature are actually more varied, sometimes using terms like youth or young adults, which can range all the way from mid-20s or even a cutoff of 30 years of age. And so there's some fuzziness as to the boundaries of evidence to guide our practice. Of course, we have more clear legal guidance on how we deal with patients in this population for consents and decision-making. Now, it's very clear that the pandemic is singularly transformative of how we work with patients in providing care, not just in the short run over this next year, but how we'll relate with our patients for the years to come, how we partner on achieving better healthcare and the tools that we use and channels that we use to communicate and deliver that healthcare. And so not surprisingly as well, in this stressful environment, our thoughts often go to the risks and filling in the gaps, and this is an important safety response. Though when things can't be the same as the predictable context we're used to before the pandemic, with new and different cognitive demands on us, we all, as health providers or patients or family members, can find ourselves feeling despondent or reverting to the older practices just to reduce our cognitive load. And just like it is for our patients with mood or substance use challenges, our tried and true responses to current stressors may not always be the most adaptive ways of dealing with the current reality. So in many ways, we're paralleling what our patients and families are going through. This pandemic is a long haul, so while we keep the risks and ways to mitigate them in mind, we can also try to lean into the strengths-based approaches that Monique and April talked about. And that's a way of promoting resiliency in our patients, in ourselves, and in our colleagues. Essentially, we have an opportunity to embody that recovery-based approach of rebuilding lives that we encourage for our patients. So let's look at the unique strengths of working in primary care that we might be able to deliberately harness, where one of the really big advantages we have is that we're often working with not just the adolescents we're talking about today, but their family, sometimes over generations or from birth. And this helps us with some knowledge and context about both potential supports and stressors for the child adolescent in front of us, recognizing that families dealing with physical, mental health, or social burdens have implications for the distress and risk for children and adolescents as well. And so in primary care, we know that we often face limitations in the amount of time we can spend due to systemic or funding structures, often much less time than specialty centers may be able to spend. But it may be easier for us or other members of our team, if we work in a team, to see the adolescent patients more frequently. And that's a significant strength. I'll come back to in particular how we implement that. And in a few moments, I'll touch on the strategies to take advantage of and plan to share the signposts of how you'll work through complex issues over time, because it all won't happen in one session. And in doing so and sharing the approach transparently with patients and families, we begin to reduce the uncertainty about the future that's so overwhelming for both patients and health team members. We also work with them on both mind and body, and that can help us identify risks or symptoms of mental health issues more easily, and also offer a start for discussion that carries less stigma about mental health, and also suggest behavioral interventions for both physical conditions that also benefit mental health status. And lastly, because of the longitudinal nature and wide breadth of the care we provide, we can and often have to work more widely with both formal and informal teams of interdisciplinary providers. And I'll come back to how this actually has changed so significantly during the pandemic. So the quick questions we're going to ask is actually, what do we focus on? And Monique and April give us a lot of really core issues. And when you're mixing both physical and mental health conditions, oftentimes you have to prioritize even further. And the question that arises is how much time do you have to spend? What is the roadmap or strategy you're going to use to get there? How do patients access you? And are you doing in-person care? Is it telephone? Is it using mobile technologies like Zoom or other platforms? And what are the access parameters for patients? Do they have Wi-Fi or good internet access where they are? Aside from all the other safeties considered, are you delivering the care alone as part of an individual practice, or are you working in other collaborative teams, whether formal or informal? And I'll go through that in detail as well. So at the beginning of the pandemic, I began recognizing, obviously, there's some early thoughts about what patients had to be influenced in both physical and mental health ways during the pandemic. And I began to consider what this meant. So admittedly, I have a small but very complex practice, and there were going to be significant issues in both these areas that were going to influence how I could take care of my patients here. And I recognize very much so, because of the stressors of the pandemic, the mental health aspect would have a much larger implication on their physical health as well. And so I started breaking down, looking at the symptoms and disorders aspect. So symptoms would change more rapidly. The disorders would need a more formal diagnosis, and there were some pre-existing diagnoses, and then there were going to be new diagnoses, and which ones were going to change and how would they change. And looking at this with a very open mind, not having preconceptions of who would do better or who would do worse, because what I noticed very quickly was some patients actually pre-existing disorders adapted very well. So for example, social anxiety disorders did really well to the shift to virtual care and virtual work. In the short run, they were adapting pretty well. In the long run, we may have other challenges in reintegrating them into work. And from the physical health perspective, I had patients with diabetes, including adolescents, inflammatory bowel disease, lupus, and juvenile arthritis. And there were acute diagnoses actually made for example, testicular cancer in our practice, and appendicitis, and how are these managed, and what are the implications for patients in dealing with this. So it's very important to me that we actually start looking at things more holistically. This is a framework that is shared as part of the First Nations, Inuit, and Métis Wellness ECHO at CAMH. It's not specific to a particular Indigenous community, but it does represent the holism in healthcare. And I think that this is very key for us to consider in the approach to care during the pandemic. So obviously it looks at physical and mental and emotional wellness, but spiritual wellness and the meaning of all this, these massive transformations in life and the significance of loss and change becomes a place to consider this formally and raising it explicitly with patients as, what does this mean for you? How does it impact you? Recognizing the impact of family on their coping during this moment and the health of family, and recognizing very much what the pandemic has illustrated, that there is no way for an individual to be healthy and safe without the community also being able to be safe, and actively asking those questions for your patients if they notice it, if they see implications, and then looking for how you can collaborate with others to address some of the challenges. And so one of the big changes was shifting to how we connected. So very early on in our practice, we moved for the complex chronic physical health and mental health conditions to virtual care. Initially for telephone to get the legal consents to actually use non-secure technologies, and then shifting quite quickly to how we used Zoom and other platforms, email with patients as well. And I'll talk about the boundary issues that arise there as well. So making sure we had verifications, making sure that access, considering if they were safe to talk in their home and their environment as well. And looking at how we could collaborate more explicitly, and email in particular gave us some of the biggest openings for how we collaborate with others. And I'll talk about some examples there in a moment here. So we also found a way to include family more often. So sometimes if family members couldn't be present, but actually were going to be important parts of the conversation or for collateral information, the patient could share the Zoom link with them to allow them to participate. We had social workers and other home care providers also joining via Zoom, even if they weren't present with the patient at the same time. So case conferences became a virtual aspect much faster, and during the appointment time that you had scheduled for a patient. And this allowed, for example, family doctors who were not part of formal teams or capitated care to actually still participate in case conferences more easily. And pharmacists were really key in actually finding out if medications were being filled or if there's challenges they encountered, as they see patients more frequently sometimes than we do. Sorry, that slide's gone backwards. And I'll talk a bit more about how we use various tools like screening questionnaires or websites or apps to support the care as well. So the next slide here talks to you about some of the tools that I'd use. So many of you are already aware of the PHQ-A, the adolescent version of the screening questionnaire, looking at mood disorders and also symptoms, and also looking at the JD7 for anxiety. And actually there is a pretty good study comparing the equivalency of using the JD7, which is patient-filled, rather than using the pediatric anxiety rating scale, which takes longer to do and can be more challenging. And this was a really significant part of my shift in practice, which I already did in person pretty regularly, but even more so now that I'm using virtual care to get patients to actually fill these out and email them back to us prior to the start of their appointments. And it's useful for screening for these symptoms and how they're coping. It's actually evidence-based for measurement-based care to know, are you making progress in a reliable way from week to week to make sure sessions are practical, or do you need to shift your strategy faster or slower? Because of these symptoms, it's a great tool for also reflection and psychoeducation about what's normal and common with various mood disorders. And it validates because you're actually building on starting from what patients' own experiences are. So the whole visit becomes focused around their symptoms, and then your approach is to help address the strategies that they need. Another big tool was actually having more formal framework or formulation framework. So we know psychiatry often uses a very formal formulation framework to understand mental health and how it fits in, looking at predisposing factors and precipitating factors, what's perpetuating the condition for patients, and protective factors that give them more resiliency. It's less common in primary care, but a really useful tool now that we have less time and need to do more structured pieces over time over various visits. It's a collaborative approach. It's one actually you co-create with your patients, where they fill in the gaps, you test hypotheses, and they work with you to help understand their status, what's changed, and how they can work forward. And I've linked there a great article you can read to learn more about this framework, and I'll show you the framework in more detail in a second. There's lots of great website resources, and I put some links in there for you. So I'll show you some pictures of these in a second, from Reach Out in Australia and the US, Youth Beyond Blue, and I'll show you what it does in particular for suicide risk. Anxiety Canada has a special section on youths, and Bounce Back Ontario, for example, is free mental health care and telephone-based CBT tools for adolescents. In other provinces, BC has it. I don't think Alberta has it at the moment. There's great apps like Headspace and Woebot, and Woebot has actual evidence specifically for adolescent use for managing depression symptoms. And CAMH has a full review for you there on the tiny URL. You can see there all the different tools, not just for adolescents, but also for adults. So this is that collaborative formulation framework that I talked to you about. So asking patients, looking not just at the biologic, psychological, and social aspects, but looking at that predisposing, precipitating, perpetuating, and protective factors. And what I've done with patients saying, today we'll talk about this. If we have 15 minutes, sometimes not more than that in primary care, but we'll work on each of these things over time. So very much transparency and signposting, and asking them sometimes to fill out in an email before their appointment if they want to put in some points there to make sure we discuss them, so we know what we're actually basing our time on more effectively. So it's a collaborative process, and you can actually ask other health providers who are involved to share more information the same way, to fill in the gaps so you don't keep on chasing one strategy, not recognizing what else actually you could do to find an opening for change. And so this is a quick screenshot to show you what the Reach Out sites show you. It focuses from everything from health and fitness to independency, relationships, thoughts and emotions, and dealing with tough times. And they can personalize it according to their needs. And I'll show you based on the evidence what adolescents themselves are looking for. So Youth Beyond Blue also has is a mechanism to educate young people for 12 to 18 years old on identifying symptoms of anxiety and depression and even suicide risk, and then promoting help-seeking behavior. So it's a self-reference tool, and there's videos and tools to go from there. Anxiety Canada has a great video, and then these tools here that can give resources for young adults and adolescents to try out. And the University of California has a really useful framework here, and a toolkit for apps to use, for mindfulness tools, for CB2, and Woebot is linked there, and that's a free tool they can use. Gamification of change, which is actually more successful in adolescents than it is in adults, and also thought diaries to work on as well. So in the end, great ideas, great tools. What do adolescents think about this themselves? So this is from the Pew data from 5 years ago, so it's probably even higher now, that show that most adolescents have access to a smartphone, and most of them, those go on online at least once a day. Even if they don't have a smartphone, they tend to go online in other mechanisms more than once a day. Even with regular phones, most were texting significantly. And that's a significant tool that some use, and I'll talk about their preferences here. And internet search to search hot topics is almost prevalent, less so for the other gamification tools and processes. We have good evidence that therapeutic alliance can be maintained with distance interventions in mobile health. So you can be reassured by the evidence on that part. And there's mixed preference for comparing in-person video and telephone preferences by adolescents here. And so what we do know, for example, is that historically in 2014, adolescents seem to prefer in-person treatment over other modes, but actually that's changed over time. So by the time you go to 2019, there was a preference for text-based communication over other forms, including face-to-face. And when it comes to our present day, when it comes to receiving resources and information across health topics, teens prefer a desire for online accessible information and health interventions, which are technology-based as opposed to in-person or telephone or paper. And that means how they want to receive health is quite different from what we're geared sometimes to deliver it. And we also know that when considering communication with the health provider, adolescents preferred email over text over video communications, and they all tend to prefer email to follow after visits as well. And I'll give you a sense of how things can change and how comfort to communicate may also be so different. So in the late summer this year, in the space of less than 5 days, 2 of my young adult patients with histories of severe anxiety disorder had relapses of substance use disorders as well, and reached out for virtual appointments. And by telephone for both of these, because they were their first visit since the pandemic began, so I had to get their consents to do anything else. And both over the telephone disclosed being sexually abused as children, and identified it was the first time they had said that to a health provider ever. And you can imagine the gut reaction and fears I had about how I might mishandle that highly charged moment without being able to see my patient or being able to see their, to show the empathy and posture or body language with them. And all in both cases with about 5 minutes left on the clock before my next patient signed on for Zoom. But it speaks to the ability to extend established therapeutic alliances that you've had over the years of primary care and focusing on discrete goals like stabilization and validation in that moment, and signposting the follow-up that both patients can have. And now both patients are doing so much better with scheduled virtual care visits regularly, and actually doing much better with both their substance use and their work. So we know that adolescents describe using technology for the healthcare to gather information, to share their experiences, to view others in order to gain social support or inspiration, or to track behaviors and health goals. They also wanted to use the technology with us as their provider to have questions asked outside of appointments, and there's clearly boundary issues and also funding and model issues that'll come into this as well, how well you can deliver on this, and have greater access to build rapport and relationships over time. And it might be simply I'm responding and your appointment is next time. And sharing data regarding behavior between visits and how that's operationalized is the challenge that we need to work through going forward. And so this last slide isn't just a reference to motivational interviewing and strength-based approaches, though clearly meeting them where they are is really a key part of work with adolescents. And we could spend a lot of time on how that can be implemented in new ways. But in the end, it's about meeting your youth and adolescent patients where they are in real or virtual space, recognizing the flora that may change over time, and exploring how some needs can be better met in these new ways. And for us as clinicians, that means modeling the resiliency and adaptiveness that coping with this pandemic requires, both ourselves and our patients. It's definitely challenging, and we face barriers and pitfalls, and here we are right now. We can be transparent about the challenges and again model the acceptance of fears, frailty, and resources for our patients. And hopefully some of these approaches can give both you, your patients, and your team some hope about how we can live and give our best during this pandemic. And that's the end of my presentation.
Thank you so much. That was wonderful. We do have a few questions. So one is, what age is the SCARED screening? Would you use the SCARED versus using the GAD-7?
So actually, I'll invite Monique to answer that question.
Okay, Monique, can you answer that question?
No, I can't answer that question accurately right now because I'm not currently using those screening tools, but I can certainly find out within moments for you and answer that question.
Thank you. That's great. We'll defer that then to the panel. Okay, so thank you so much.
So
And do
did you-
any of the panel, does anybody use the CRAFT to screen, the CRAFFT, if you're to screen adolescents for substance use disorders? Javid, do you use that?
I haven't used that one yet. Actually, that's the one challenge we're seeing. April actually has a comment to make, though, I think.
Yeah, sorry, I was just taking, technology. It was taking me a while to open my mouth. People would say that's probably good in real life too, but so yes, I do. What was the question about that?
Just do you use it? It hadn't been mentioned, or at least I didn't see it. So I know, I use it in practice as well. So I just wondered, what your thoughts are, or if the audience, if that would be a, another resource that our participants would like to be aware of.
Definitely. I think I mentioned it. It's one of the screening tools. I definitely use it. And you would even be good to use the CRAFT interview version 2.0, which actually has been updated. So the original author was Knight back in 2002, but now in Boston Group has updated it. And it starts with the first 3 questions. During the past 12 months, did you drink more than a few sips of beer? Or any alcohol, and then any use of marijuana or synthetic marijuana. And then the third question is, did you use anything to get high? And if they answer yes to any of those, you do the whole CRAFT. If they answer no to that, then you if they answer yes to any of those questions, you do CAR. And if they answer no to that, then you do the whole CRAFT screen. And then that just helps to move things forward. And then they also recommend ways to follow up those questions, whether they answered yes or no. And I can give those that reference as well.
Thank you very much.
That's great. So thanks so much, Dr. Alou. That was a very interesting talk. I do see we're starting to accumulate some questions, and just a reminder, we will have a chance for a Q&A session with all of our speakers at the end. So if you have questions, please continue to put them in the Q&A box. We'll also try to skim the chat to see what questions are there as well. Our next speaker is Greg Lubimiv. Greg is the Executive Director of the Phoenix Centre for Children and Families, which is a children's mental health centre serving Renfrew County in Ontario. Renfrew County is the geographically largest county in Ontario. And over the last year, during the time of COVID, Greg has been involved in a number of projects to improve virtual care in the Ottawa region, including a primary care pathways project with the Ontario Centre for Excellence for Child and Youth Mental Health. Welcome, Greg.
Thank you so much. It's such a pleasure to be here with you. And I really enjoyed the earlier presentations. I really want to talk a little bit about, take a different viewpoint. And first of all, I have no affiliations, so don't make any money, don't have any royalties. Just a poor social worker trying to do a good job. Go to the next slide. So just to give you some context of the Phoenix Centre, as I said, we live in Renfrew County, which is the beautiful Ottawa Valley. We are the only children's mental health center serving in this county. We're an accredited agency. We have about 20 therapists and a staff of about 40 with administration staff, management, and IT, etc. Our services include our crisis service. We have an intensive in-home service. We provide the mental health youth justice service. We have telemental health or telepsychiatry. We do attachment work. We do trauma work. We have groups. We have school mental health work. We have walk-in clinics. And our largest program is our outpatient program. And we serve about 1,500 unique individual cases a year. And our clientels need to be between 0 and 17 and their families. Next slide. Here's sort of a picture of our county. We have 7,000 square miles. We have a massive population of 100,000, which is less than many urban cities. Our largest community is 15,000. We have 17 municipalities with some as small as 100 and going up to our 15,000. We have 5 hospitals serving the area, and we have 2 regional hospitals in Ottawa that would serve on the pediatric side, CHEO, and the Royal serving the adult side. We have lots of challenges in terms of our rural life. We have higher unemployment rates. We have higher addiction and substance abuse rates. We have higher poverty rates. 20% of our population do not have a physician. There's no public transportation system. There's no public buses. There's in Pembroke, you can get mom and dad's taxi. And if they're not busy, they'll pick you up and take you where you want to go. Next slide. So one of the things I want to talk about is our approach to mental health and addictions. And it's not talking specifically about adolescents, because what we realize is that each of us doesn't have capacity, whether it's the education system, the adult mental health system, the children's mental health system, the addiction systems, the residential systems, the senior systems. We are all poor. And I don't think that's that different from urban centers. We have challenges in terms of the huge geography that we have and how do we cover all of that equally. And so the large centers, which are sort of along Highway 17, Renfrew, Pembroke, Petawawa, and Deep River, and Arnprior, which you may be familiar with, those are our larger communities ranging from 5 to 15,000, and all of the services tend to be able to be provided there, and there's access there. However, when you get down to areas known as Barry's Bay or Combermere or Douglas, these are tiny communities that are 30 minutes away, 1 hour away, 1.5 hours away from various services one way. And without any public transportation system, it means that families who don't have access to cars, or the cars aren't working, or they can't afford the gas, or they can't afford the 25 cents. It's only 25 cents to park in Pembroke, by the way, so there's an advantage there. That access can become a real problem in rural life. We also recognize that there's issues in terms of the silos of agencies that we have, whether it's working with a child or an adolescent. Let me give a case of, I was talking to one of my staff, 15-year-old who's going to the high school and struggling with all kinds of issues. And the worker finds out that she has 6 other service providers. The doctor's been working with her on some mental health supports. The guidance counselor has been working with her. The school social worker has been working with her. Children's Aid is involved, and child protection work has been working with her. The in-home child care Children's Aid worker has been working with her. Our worker is working with her. None of them talk to each other. There is no common plan. And this girl was actually overwhelmed with all the different things that she was having to do, and the action planning and the different approaches and the different techniques that were being used. And it was the service system was actually adding to her stress and her being overwhelmed as opposed to helping her. Unintentionally, of course, but it was a fact. We have issues in our adolescent world in transition to the adult world. It's like falling off a cliff in Renfrew County, that there is much less adult support. There is less free adult support. And so you have a 15-year-old, a 16-year-old turning 17 and now turning 18, and we know they need long-term service. They're borderline, they have major issues, and we're trying to move them into the adult system, and they might not be picked up for a year, 2 years, 3 years. What happens in the meantime? We looked at all of those different pieces, and as a county, we sat down with all the different agencies and said, we need to fix our mental health and addiction services. We need to find a different way of working. And we formed a planning table. And in that planning table, we said, much like said earlier about the need for a holistic viewpoint, we need to think systems. And we followed the social determinants of health, really believing that mental health is very much affected by poverty and by education and by finances and by employment and by family background, et cetera, et cetera. And so we pulled together a planning table that has 22 different sectors represented, with 2 representatives of each. So addiction is represented, the military is represented. We have a large military base, the largest military base in Canada in Petawawa is here. And about 25 to 30% of our cases are military. The First Nations, we have Francophone, we have youth, we have LGBTQ, et cetera, et cetera. You can see the list of people who we have bringing different perspectives, bringing different worldviews. What's important in this particular conversation, we also have 2 youth, because we believe that youth, adolescents, have a different context in how they see the world, and how they meet the world, and how they need to have services provided. And so that youth voice brings a lot of sanity to us as we design some different types of programs or activities or services. We can check back with those youth, and they actually can check back with their community of youth and say, you know, you guys are off your rockers. This isn't actually going to work. We would never go to that. We would never do that. We would never respond to that. Here's how we need that. Or how would we get to that? You're putting this great program in Pembroke, but 80% of the population is between 30 minutes and 2 hours away. How do we get there? And you're doing it at 1 o'clock. We're all in school till 2:30. How does that make sense? So thinking about how we design services, how we activate services became our mission. In that, we did focus groups with youth, we did focus group with caregivers, with service providers, with all of the various stakeholders, including businesses and municipalities and Ontario Works, and said, what is it that we're doing well and what is it we're not doing well? The list was a lot longer for what we don't do well. And we also talked with primary care, and that list was also long with primary care in terms of what was failing in our system, in how we were operating and how we were being accessed, and the criteria we used, in how we move people in and out, the wait list that were anywhere from 2 months to 6 months to 1 year, depending on the program. And we identified 3 priorities out of that in 2016. One was, we need to improve intake access. People are not sure where to go, how to get there, and are they getting at the right service at the right time? The second area was creating an integrated crisis system. We had people going into the emergency rooms with mental health crisis at age 12, at age 16, at age 60, and they would be stabilized and they would be demitted. And the mass majority of them were not connecting to any type of mental health service afterwards. There was no communication outside into community agencies to say this person had been there. So we might have that person on our caseload and we wouldn't even know that that adolescent appeared at the emergency room. We also, they wouldn't know necessarily that we were working with Johnny at the Phoenix Center for the last 6 months on his depression. So we needed to think about how do we fix that crisis system? And finally, how do we improve pathways between services? So our results, go to the next slide, please. So what did we do? On improving access intake, one of the first things we talked about was getting people to the right door at the right time. The old way we did things, we go to 0 to 17, so we get a 30-year-old coming in our door at the Phoenix Center, and the receptionist say, oh, you don't meet our criteria, you're an adult, here's a number, or here's a list of agencies you can call, good luck. And they would leave. And they might call one of those numbers and contact that agency and say, yeah, I'm 30, I have this, oh, that's not us, here's a list of agencies you might try, good luck. And we lost a lot of people that way, who gave up on not getting to the right door, or gave up because they didn't feel that they were welcome or invited or were important or valued. And so we looked at 16 agencies, which would be the majority of agencies providing mental health addiction services, and created a community of practice with the intake workers and adopted a protocol that's called Connecting Everyone to the Right Door, which is a warm handover principle. So now that 30-year-old comes to the Phoenix Center and we say, you know what, this isn't the right agency, but hang on, sit down for a minute. We're going to figure out where you need to. Tell me a little bit more about yourself and what you need, where you live. Okay, that's great. So I'm going to make a call. I would call the adult service down the road and say, I have Johnny here. He's 30. He has these conditions. Does that fit your criteria? No, actually, that's agency B down in Renfrew. Ah, here we go. I'm going to call agency B. It's my job. I have the baton. I don't give the baton to the client. I need to give the baton to another agency. And that client then is able to be accepted there. So we've been running that for about a year and a half now, and it has changed how service access works in this area. Our community practice, those intake workers, those 16 workers meet quarterly, and they share, hey, we've changed this, we've added this criteria, we have a new program, and they talk about challenges or problems. And if there are complaints or issues or concerns where it didn't work, to talk about that and say, you know what, this fell through the crack. Why did that happen? How is it that this person didn't get to the right door or the protocol wasn't followed? We actually have signage that we created that are on the in the waiting rooms of each of those agencies in English and French with our protocol. Next slide, please. Integrated crisis system. So we piloted with our largest hospital, Pembroke Regional Hospital, a new system for crisis a year and a half ago. Again, I did talk about those problems in terms of the lack of communication after a person was there. They might show up 3 more times and may be treated very differently each time. Sometimes admitted, sometimes not admitted, sometimes referred, sometimes not referred. Doctors, nurses saying, I'm not sure exactly where to refer them. And if I do refer them, I don't know what happens to them. Nobody tells me if they accepted them, if they got into service. So we were as much at fault in terms of not communicating back. We also had several doors out. So do you go, if you're adult, there are several adult agencies that you can go to, or addiction agencies, 2 addiction agencies. If you're children, you usually come to us. But if you're from Deep River, there is a Deep River Family Service. If you're military, there's a military family service. If you're in Arnprior, there's actually a small agency that will work with children there, or people can go to CHEO. So confusing in terms of what's going on. And what we talked about at the table is how do we change that? And what we heard from youth and from caregivers is, you know what, we don't really need to know the protocols and the criteria and the processes. We just need to be directed to the right place. And what we designed in Renfrew County with the adult services, the major adult services, community mental health services, who have a mental health crisis team, is they actually become the one door out. So they said, they took off the criteria. They start at 16, we go up to 17. So what we have 12-year-olds that might present an emergency mental health crisis, or a 13-year-old or a 14-year-old. And they came to the point and said, you know what, we don't care what age they are. No matter what age they are, all referrals from when they're stabilized will come to us, and we will then do the warm handover. If they're child, they go to Phoenix Center, or if they're addiction, they go to one of the addiction services, but we will put them in the right place at the right time. The client doesn't need to worry about it. The doctor doesn't need to worry about it. And that's what we put in. Secondly, that all the emergency room practitioners would use the same screening instruments, the HEADS ED. And that became standardized, and we did some orientation, did some training, and the fear from many of the primary care and the health professionals was, you're creating more work. What they found is that actually it made less work. It was very easy to complete, and it gave us common language, common templates that can be used by all the service providers and by the emergency room docs and nurses. So what happens is you have mental health crisis, there's a screening, they are assessed for whether they are low level, medium level, or high level urgent, they're stabilized, and then they go to the community mental health. If they're an adolescent, they come to us. We get that form, and we would see that child or youth within 1 working day of that referral. And if it's not urgent, it'd be within 5 working days. The more beautiful part of this protocol is not only that we receive the referral, but we report back to the emergency room that they will get back a template from us that says, you know, you referred 15-year-old Johnny. We tried to contact him 4 times. We called the family, we visited the family, we wrote the family, we're getting no response, and we're closing the case. So they know that the next time Johnny might appear there, they would see that in the record and perhaps do the referral a little bit different way. They might keep him overnight and call us, and we have a worker actually go over there and meet Johnny and the family to break the ice in terms of that stigma that might be attached. Or we would say, you referred Johnny, we connected with Johnny, He's now in treatment, and we're working on some goals with him. So again, they would know exactly what happened. What we missed in this, and we are now at in our pathways to our primary care pathways, is the community docs weren't getting that information. So the emergency room was now in good stead. We were in good stead. We have this nice relationship, communication going back and forth. But the community doc who might be working with Johnny doesn't have a clue what happened. They might know we went to Emerge, but they don't know he came to us, and they didn't get the communication back from us. So we're now meeting with a panel of doctors and health professionals to try and look at how do we break that communication system, bring that communication system so that the primary care world is hooked into the mental health and addiction world, and that we have protocols that allow us to provide that information back and forth in terms of what's happening and really do better care. Next slide. So adopting the HEADS ED was certainly a huge piece. The Columbia for the adults, the HEAD ED for the pediatric side, orientation of the ED staff, one door out from the ED, community agencies 17 and under to us, 17 over to be to one of the adult services. We have a strong protocol, and we also identified if a patient returns 3 or more times in 1 year to the emergency room, it would call for a special case conference. Next slide. So we want to spread this out to the next 4 hospitals, and we want to include primary care in a more integrated system. We want to create data systems to track and measure outcomes. We think that there are reduced numbers of presentations. Now, COVID is in the way of all that data because it's really changed how people are attending hospitals and how crises are coming in. But we want to actually now do an evaluation of this. Next slide. Pathways to care, the other one, how they move back and forth to agencies. And I'm not going to talk a lot about that because it's we're still working on that. Next slide. So virtual care, you know, as much as COVID has been a pain in the rear end for us and a stress for families and for individuals throughout the world, it also created some huge benefits. And one of the things it did is it pushed all of us to jump in the deep end of the pool around virtual care. Some have been dabbling in it, some have been doing it for a while, but for the most part, we were not embracing it. And with that jumping in the deep end of the pool and having to force ourselves to adapt to this new world, it really prevented some interesting benefits, especially for the rural world. Our clients, many of our clients actually love virtual care. They live an hour away. They now spend less time traveling in bad weather. We had 13 snow days last year, and all cases were canceled that day. In this new world, we would not lose any of those days. We would say, no, don't have to come in. We'll just see you at home. Just turn on equipment, and here's a link for you to connect to your provider. That through the virtual care, also, we noticed right away that people were starting to duplicate efforts, figuring out what platform to use, struggling with training, struggling with equipment. And we very quickly developed a large body a collaboration for the whole Ottawa Valley and the Ottawa and Renfrew County, Ottawa, Prescott Russell. It's called the Champlain region. And we were provided funding from the United Way for a virtual care project. And a virtual care project allows us to create a centralized way of providing equipment connectivity to providers or clients. So right now, if a client needs a cell phone or needs a tablet or needs connectivity, you don't have to figure it out as an agency. You call, we host this program, you call our coordinator and she gets a phone out to that person. She figure out where they are. What is it, a Bell service that works better? Is it a Rogers service or a teleservice? What kind of phone is it that they require for the type of care they need? Are they doing texting? Are they doing video, etc.? And then she would get that to them via delivery. We got together and we created best practice. We created templates for documents. So again, each individual agency didn't need to figure it out on their own. We did it collectively. In that collectively collection, we also are working with a pediatric collaboration with Sick Kids called Kids Come First for the whole region, where we are moving towards one call, one click for coordinated access, so that something like 75 to 80 organizations will be connected to one number that we can get referrals. We still get referrals directly, but if anybody is not sure where to go, they can go to the central number and be navigated to the right place at the right time. We're now working on a virtual care walk-in. We had walk-in going for 4 years. It's an amazing program. It actually increased our capacity. We got to a no wait list, and we're still at a no wait list at the Phoenix Center for the last 1.5 years since we started walk-in. We moved into virtual walk-in and very quickly recognized that we didn't have capacity to cover a lot of days. And we also didn't have capacity to cover the needs of different groups, like the addiction needs. We don't do addiction work, or the adults, or the emerging adults, or the seniors. And so we are now developed a program with 12 agencies, where in January we're launching a unified walk-in where clients can actually go into a website and pick a session that they want based on their needs, their age, the type of issue they want. They get their session, and it goes to that professional, and then they see that client in that single session model. Doing the same thing on the walk-in with adult, children's, and addiction workers being available at that walk-in virtual. This could never have happened if we had stayed face-to-face. The other exciting thing that's happened is virtual groups. So we are now at a point where many of us aren't offering groups, we're starting virtual groups. And I've been saying at other agencies, you know what, I run an anxiety group for adolescents, and I have 5 seats, but I could run for 15. Why can't an Ottawa child or a Toronto child or a Prescott Russell child, or if we were massively across Canada, someone from Calgary, attend that anxiety group virtually? Geography doesn't matter anymore. And we recognize that this power of virtual is allowing our capacity. Well, we cancel almost 1/3 of our groups because we don't have enough. In virtual groups, we'll never cancel a group again. We will have every group full. And I have access. I might run 2 anxiety groups at the Phoenix Center a year for adolescents. In a group of 50, 60 agencies in the region working with adolescents, there'll probably be an adolescent anxiety group running every 2 weeks starting. And so I have access not just to my group, but to now 26 groups ongoing. And there'll be very little, if any, wait list for those who are in need of group, whether it's for depression or anxiety or grief and loss. We're experimenting or exploring the idea of DBT being virtual. There is some controversy whether it can work as well, but we're willing to give it a shot. And we're finding that much of the virtual group is working just as well as the in-office group. Virtual training, training of professionals that we're gathering ways of collaborating, training, of creating videos on training that can be accessed on a single site where service providers can go there and play a video on working with creative ways on working with adolescents virtually, and giving some tricks of the trade in terms of using engaging play-based activities with children, with adolescents, etc. Or if we do training on single session, we now open it to the whole region. We don't just do it for the Phoenix Center. We are looking at, in virtual care platforms, collaborative licensing. Right now, we pay at the Phoenix Center $30 per user for a license for the healthcare version for Zoom. And we have talked to Zoom, and if we get to a certain number of users, it'll be down to 20. And if we increase that number of users, it'll get down to 10. And I am quite convinced that we're now in the process of gathering who wants to collaborate on whether it's Zoom or Doxy.me or other platforms that you pay for, getting enough volume that we can say, let's make a deal to these companies so it doesn't kill us in terms of this new expense when we move out of the special COVID dollars that are covering most of this into the new year. Next slide. And that's it. So there's so much more I could say, but I'm so excited by the opportunities that the virtual world has brought us, that we also though need to make sure that we're designing our services for adolescents based on their needs. You know, I was talking, let me just one last story. I was talking to adolescents about our crisis line, and we have a 24/7 crisis line that you could phone. And I said, how many would use it? And there were 12 adolescents there, and one put up their hands. I said, well, but you know, everyone says you need it. You know, this would be great. They were like, what's wrong with it? We don't want a phone. We want to text. And we didn't have in place texting that everyone felt comfortable with. And now we're engaged in doing that. Facebook, they said, we developed our Facebook page. Said there, we're up to date on our social media. Adolescents said, we're not on Facebook, guy. You got to get on Instagram. Oh, what the heck is that? So we need that youth voice, not just to tell us what their issues are, but to be part of designing new systems. So thank you very much.
Thanks so much, Greg. That was fascinating, and I think kind of inspiring for myself and for a lot of probably our rural family physicians who are watching tonight, just to think about using this as an opportunity to not just catch up, but to organize in new ways that are probably more advanced than what we've been doing. I think we'll move right into the question and answer session. We have a couple of questions that have popped up in the Q&A. If anybody who's watching the webinar has a question, please type it into the Q&A so that we can get to it. The first question there is a question about Wobot. Do you find that it's been a good resource for patients who can't or won't access counseling in other ways? And I'll ask all of our panelists to turn their cameras on and let's toss that one out there, Wobot.
I can get us started on this. So I think a really good way of looking at how we use all these different tools. So there's been all this plethora of apps and websites, and I shared a couple of them, but the reality is just doing that, avoiding that writing reflex, not just to give a solution right away, but really to think about the process of how a patient client is coming to you first. Otherwise, the adherence rate or utilization of any interventions we give, whether it's medications or psychotherapy or apps, which are other tools in that spectrum, just won't happen. So first understand the context, which is why I talked about a formulation tool early on, to really have a sense of where and how this process came about, the situation for your patient first, and then looking at sharing how these tools work. So the first part of the conversation is in helping people feel seen and heard and their context and needs understood. And then helping them and suggesting having a conversation about what tools and solutions like an app might be effective for them. And so patients who either couldn't get access to psychotherapy, but who are interested in psychotherapeutic approaches, the app was particularly useful. Obviously, people are more comfortable with text sometimes. And so to give you some disclosure about Wobot in particular, a very small world. So I actually knew the developer of Wobot when she was finishing her PhD master's before she created Wobot in the years she was spinning off from Stanford to do this. And so she described a very formal, strict, rigorous process based on our understanding of CBT that informed her product, which was great. I actually didn't recommend it that highly for a couple of years because we didn't have the evidence of value. And now that from 2017, we can see what it does for adolescents, for example, depression, I feel more comfortable now recommending it and explain to patients what to expect from it. And so my colleagues at CAMH, when they heard about it from this recent review as part of CAMH's list as well now, the psychiatrists and the internal medicine doctors start downloading it and playing around with it for themselves. And so you might want to look at it that way so you can explain what and how it works from a personal experience as well. And I found that was helpful. So for patients who actually gravitate towards thinking cognitive approaches, the CBT approaches is something that they're open to. They like the fact they can deal with it in the moment of their crisis to work through learned skills there. So really presenting the skills augmentation process has worked really well. So I'll stop there.
I'm not too familiar with Wobot, but I know I'm familiar with a number of apps, and there's many different online programs to assist youth in their challenges. I would say that a lot of those products are really aimed more specifically at the low level to medium low level issues or challenges. That there really needs to be some resilience or some strengths in that individual to use them well. For the others, as a supplement, it's good, but as a single dose of or medicine, I think it can be dangerous actually, and I worry about it. So that and what I wish there was on those applications is some type of a screening, which would say, you know, have there been changes for you? And if after 2 weeks there aren't, it would say, you know, you should go here. Here's a place to connect to. So that's my thought of it. That for the lower level, I think it's a great thing. For the higher level, the more complex cases, it's a great supplement to use. You know, so I use something like the heartbeat. It's a way that I would bring in when I'm doing stress reduction or mindfulness. They can actually see their heart rate change from that. But to just have someone take that who's in a high challenging stress area and to use it, I think it would not necessarily be in a good direction.
Thanks for that. We have another question in the chat here directed to Dr. Elliott and Dr. Jericho. Someone wants to know, how do you incorporate wellness into your own practice?
It's such a great question, and and there's different ways to kind of look at that. There's sort of personally what I've discovered about myself, and then there's some kind of broader themes and concepts that come to mind. And I think first and foremost, as providers, particularly now, it's that self-awareness that's so critical. You know, we have to really make sure that we are moving beyond this idea of the physician hero. You know, even though we have been lauded as such, and I think that society is needed to see healthcare providers in this light, we all know that we are people and we are vulnerable, and particularly vulnerable to the symptoms of burnout, depletion, depersonalization, and so forth. So, you know, what I think about, I think about a few different things that are helpful to me. Debriefing with a colleague, which is something I did earlier this evening with Dr. Elliott. We are fortunate in that we are work spouses in a lot of ways. And I do think that's incredibly important to have somebody in your corner with whom you can share not only things that are challenging, but also things that are successes. So having the opportunity and taking the opportunity when something is nagging at you, you're uncertain about something, really getting that off your chest and trying to prioritize a little bit of space and time. Doesn't take long. Reflecting on process is a big piece. We oftentimes focus exclusively on outcomes, you know, when something either goes well or it doesn't go well. You know, sometimes, you know, we can leave an encounter and somebody's upset, somebody's angry, somebody doesn't like what we said, you know, and we can't always control that, but we can always reflect and say, hey, you know, I went through a really good process there. I really did something thorough, and I'm pleased with, you know, the stance I took. It was the right thing to do. So, you know, reflecting on that, really, really important. And in the burnout literature, that is very important, and it's punctuated. You know, I'm going to leave it to Dr. Elliott to talk about gratitude, because she's now known as the gratitude guru here at our hospital. But really, the notion of celebrating successes and sharing that with your team and noticing it in other people around you, right? We all influence the cultures in which we exist and in which we operate. And we can all play a wonderful role in sort of bolstering our community. So those are some thoughts, but Dr. Elliott, gratitude guru.
What are we grateful for? Starting every meeting or interaction, asking someone what they're grateful for can really put you in a positive emotional place. I think it's really important to go back to values and recognizing what are your values. Also as an executive coach, when I meet with people, I start with values, because so much of that is the foundation of why we make decisions. And sometimes we're working in a culture that doesn't have the same values as us. And so recognizing that is really important for your own mental health. And listen to your body. I can't tell you how many times people go without going to the bathroom or go without having breaks. And especially now when we're back-to-back Zoom, schedule in those things. And I'm very intentional about that. Sometimes things run over, but if you can, make sure that you're blocking off some time for yourself as well.
Thanks for that. Deborah, do you have a question that you can ask the panel?
Absolutely. So this one, this can hopefully be answered by all of you, but Greg, if you don't mind, I'm going to direct it to you first. One of the things that, you know, that you had mentioned was the, the kind of the limitations on data collection, and I'm going to add research on there. So I always find the balance, no matter where you are, whether it's in a larger center or a smaller community-based organization, between providing frontline service and getting data, right, to not only help your clients, but also to show that what you're doing is making a difference in your communities. So can you speak to that a little bit?
Yeah, thank you. It's a great question, and the whole issue of data is a complex one. And in this new world of integration, it's actually one of our challenges because we all have different data systems that don't talk to each other. However, in terms of data itself, we need to be data driven. We made that decision at the Phoenix Center about 10 years ago, but it took 5 years to get to the point where we actually were being able to use data. So there's a difference between collecting data and using data. We collected data for the last 40 years, and I'd say 90% of the time never used it. Didn't know how to use it, didn't know how to collate it, didn't know how to understand it. And when we decided to be data driven, we started to look at why are we collecting this data? And if we didn't know why, we actually stopped collecting half of the data we were collecting because we didn't have any use for it. We just thought someday it might come useful to know that. And that started to change our thinking. Our data started in terms of looking at volumes and efficiencies, and in the last 3 years, it's shifted to outcomes. And that is really where we need to make our hard landing. What difference has happened in the life of this adolescent from when they came in to the middle to when they've left? And there are some really clever ways that have been developed around using different either screening tools or evaluation tools, even self-satisfaction tools, even something as subjective as a youth saying, when at each session rating whether at 1 to 10 what stress they're at or how helpful they felt it was at the end of a session. And there is standardization of what's called the OPAC, the client response, looking at every session, getting that response, and actually seeing a graph of how they're doing in your treatment. Are they moving up? Are they moving down? Are they blipping? So I think we are in a world that is now in a much better position. Our next challenge is going to be, I think we have to move more to integration. We have to move to collaboration, but data is one of the things that's in the way of that I have EMH where Hospital A has Epic, Hospital B has the Phoenix program, Hospital C has the Sandtrap program, whatever. And that's something that we're currently trying to figure out.
Thank you so much. That was that hit most of the points with that. It's very tough. Did anybody else have anything they wanted to add coming from your perspectives?
I would make just a comment about integrating data. I think that if you are collecting data, I couldn't agree more. You need to know why you're doing it, but you also need to create a culture around you that's invested in collecting data. And in order to do that, you need to make it clinically useful. So ideally, you're collecting data that will help and support your team in the work that they do and will help and support the patients. And so if you can collect data that you can feed back to the patient and incorporate clinically in the immediate sense, that can be fantastic. It can be a wonderful addition actually to sort of what you're doing in the room with the patient or on Zoom with the patient. And it's sort of sustaining the culture around you. And doing that, you need to give people feedback. What did we learn this year? What did we learn the last 6 months? And that can actually keep people really enthusiastic. And can really drive change in an organization. It happened in our clinical community. People were really daunted by the notion of collecting data, but now they see so many benefits and they actually really look forward to the updates. So
I can add a little bit more to that as well, if you like.
Sure.
So what we're really talking about now is the intentional approach we're taking to working together. And recognizing that this pandemic has really, because of the privacy loosening that we've had, allowed us to focus on doing the right thing. and up till now. And so recognizing the intention and the decision made from a legal framework is that the outcomes were more important than a mechanism that is important. So privacy was important for a value for patients, but if we weren't delivering what they needed, then privacy was less important than delivering what they needed in most cases. And so what this allowed us is an open field to use the tools we have, including email that we've used to organize and work together in every other arena except for healthcare until now, to actually see how we actually make the connections. And so a principle that IDEA, which is one of the design firms that intentionally looks at design of health systems and other processes, used at Stanford was paving the cow path. So first of all, they didn't have their open field that they had there in Stanford. They didn't actually put up walkways for students. They let the students walk where they did for a year or two and see where they wore away the grass. And then after that, they actually cemented those pathways to make them formal pathways. So using the tools we have like email right now to explore what could be done to link together providers to work together, that's directly, as Monique mentioned, working with patients, showing them the value of this, and actually keeping very focused to the value that's derived rather than abstract organizational level only, and then looking to ways to incorporate the best outcomes here to a way that organizations can work with or your team can work with more formally. So being willing to be creative, mitigating the risks about having over boundary sharing and issues like that, but not losing the value that could be derived if we learn how to do this well right now.
Thanks for that. As we come into the last minute of our webinar here, I just want to take the time to say some thank yous. I want to thank the DLRI staff, my staff who I've worked with in the office for years and now out of the office for almost a year, who do all of the hard work of behind the scenes, from helping us to get CME accreditation to running the logistics of the webinar. So a big thank you to them. I want to thank the speakers. I think we've been very fortunate in all of our webinars to have great speakers, and tonight is no exception. What a great panel, and what an inspiring group of people to listen to. I want to thank McMaster for being willing to partner with us to see how this went, to take a chance, and I hope it's been a good experience for you as well. I want to thank my co-moderator, Deborah, who's been very helpful in putting this together. And I want to thank all of our attendees, the physicians, the other health professionals, the teachers and preceptors out there who, after a busy day and after weeks and weeks of many hours on Zoom, have taken time out to try to learn something that's going to help their patients. So a big thank you to you for coming tonight. Deborah?
Yeah, I just wanted to echo those thanks, Aaron. It's been an absolute pleasure, and as April is the gratitude queen, I'm going to say that I am grateful for being able to be able to do this, and I look forward to further collaborations, because this is it's a learning. It is a wonderful learning experience, not only for all the attendees, but also for us on the panel as well. And I just really appreciate it. And I want to thank everybody for attending. Very pleased with the turnout. And so special thanks to many of the people I saw on the list who I certainly know and work with. So you know who you are out there. So thank you very much for coming.
A reminder to everybody that you'll receive a survey in your email that you used to register for the event tonight. Please do fill that out. We take those surveys very seriously. We'll feed some feedback back to tonight's speakers, and we'll also use your suggestions to develop our future webinar offerings. And finally, this is one in a series of webinars for us, so please stay tuned. Check out our website at ucalgary.ca/ruralmed to see what kind of webinars we're having in the future. Our webinars are CME accredited, free, and connect you with colleagues from across the province and now across Canada. So I'm going to close with that. A big thank you. I appreciate your time and appreciate that, and I hope you've had a good evening tonight.